Hello, listeners and viewers. Welcome to the Future of Human Health and Medicine Organization's guest speaker series. My name is Ryan Davis, and I'm a FHHMO Ambassador from Severna Park High School. Today, I'm pleased to be joined by Dr. Clifford Solomon. Dr. Solomon is the director of the Spine and Neuroscience Center at University of Maryland, Baltimore, Washington Medical Center, and specializes in neurosurgery and spine surgery. He received his medical degree at the Medical College of Pennsylvania and completed a residency and a fellowship in neurosurgery at Johns Hopkins Hospital. Dr. Solomon completed additional training at the University Hospital Zurich in Switzerland and at Memorial Sloan-Kettering Cancer Center in New York, with a focus in neuro-oncology. Thank you so much for joining us, Dr. Solomon.
Thanks for having me, Ryan. Appreciate it.
Absolutely. We look forward to hearing from you. So starting out, start off pretty basic, but what first got you interested in the field of medicine?
I grew up in Baltimore. I went to Gilman, which was probably the best thing that ever happened to me in the sense that, like any high school, if it's a good fit, you kind of are able to get a little traction. And so there, I think if it had been laid back, it might not have been so good for me, but there it was fairly rigid. And because of that rigidity, it kind of taught me early on some good study habits. And then as a senior, like you guys are, I went to, it was called Encounter. And so as a senior, they'd send you to do something you were interested in. And my dad was a doctor. He wasn't a surgeon, but a medical doctor. He had trained in Baltimore at Hopkins when I was born. And I kind of grew up going with him to the hospital. And I remember very distinctly as a young person, 7, 8 years old, saying, will you take me to surgery grand rounds? And he said, well, I'm a medical doctor, so we go to medical grand rounds, but it would be kind of weird going to surgery, but I guess I could take you. And he took me, and he said that they're talking about your dentist up there, and he had a brain tumor, and his 3 children had brain tumors. And I was really struck by, one, I knew the person was my dentist, and 2, that his 3 kids all had brain tumors. And I thought that was like crazy. I mean, it was just so bizarre and very humbling and sad all at the same time. But I really was moved by the neurosurgeon who spoke about it and thought that that might be something I would do. And then fast forward to, it's funny, Gilman, the guidance counselor, said I went and did this thing for a month at Falston General, which is now Upper Chesapeake, followed a general surgeon around when I was a senior in high school. And I came back and said, I want to do this. And the guidance counselor said, you're way too happy and easygoing to ever be a surgeon. You need to be, not so nice, and you're too nice to be a surgeon. Which he didn't quite say I wasn't smart enough or something, but it wasn't the biggest, oh, you can do whatever you want kind of speech from a guidance counselor. And so that was interesting. And I would just say, as something to someone young who has ambition, that if I can be a neurosurgeon, you can do anything you want in this world. And if I can get trained at Johns Hopkins, there's no limits for anybody. I would just say that persistence beats resistance. And, you get knocked down in life, you get back up and brush yourself off, and you can do whatever you want. And don't let anybody tell you otherwise. If anything, use what somebody telling you can't do something to prove that you can do something, because nobody, has that power over you. So then fast forward to medical school, and I was in Medical College of Pennsylvania. My first surgical rotation was neurosurgery. And I didn't know where I was supposed to go. Apparently there was orientation. I didn't know about that. I went right to the operating room. I looked on the schedule, went to the OR. It's the first time I'd been there. And I think the nurses were kind of messing with me. They told me to go scrub, and I was scrubbing and my hands were like raw. I didn't know how long to scrub. And then I walked in the room and they're like, no, put your hands up. And I put them up. No, not that high up, put them down lower. No, in the middle between here and here is sterile. And then the surgeon came in a few minutes later and he goes, you must be the med student. And I go, why is that? He said, well, we're not getting started for another hour and a half easily. So you can, you don't need to be, all ready to operate. So he said, I want you to come to the locker room with me. I need some help. So he said, take your clothes off. And I thought that was kind of weird. So I then put your street clothes on. So I did. And he said, I need you to go up to the hardware store, Ace Hardware in Philadelphia. I need 20 tubes of super glue. And I go, for what? He said, for the surgery. I said, really? He said, yeah, this woman got shot in the head a couple of years ago. And she has been, hang on, sorry. The getting a phone call. Hang on. Let's see. Are you still there? Let's see. Let's see how to get you back, Ryan.
Right.
Ryan, are you there? There you are. I got a phone call, so it kind of took me out. I didn't answer it. And so I run up to the Ace Hardware. I said, I need 20 tubes of super glue. And the guy goes, for what? I said, brain surgery. And he hit the lady at the checkout, and they laughed. They gave me the super glue. I went back, and this woman had been shot in the head a while ago, a couple of years ago, and fluid was leaking out of her nose every day, spinal fluid. And she'd had multiple attempts at repairing it. And basically, they were going incision from one ear over the top of the head to the other ear, take the skin down forward over the orbits, the eyes, take off the whole forehead, lift up the frontal lobes, and then put some temporalis muscle under the defect and the super glue. And I was like, that's insane. And I remember saying, is that, don't you worry about infection? And they're like, no, we don't, nothing sets up on super glue. Her brain and her spinal fluid have been in communication with the world for a long time. It's not a big deal. So he was ahead of his time, and we were under the microscope, and I was watching, and he was dictating. And he said, and here you can see the hole in the perpendicular plate of the cribriform bone. And we're going to now put a little temporalis fascia over with a little tissue adherent material. And he steps off the pedal, the dictating, goes, all right, give me the super glue. And he like squirts it into the brain in the skull base under the frontal lobes. And then he turns to the chief resident and says to her, okay, why don't you close? And by then the medical student and the other med student and the residents had dropped out. And we were probably into hour 12 or 13 of the surgery. And she says, do you want to close with me? And I said, well, this is my first day, And she said, you know how to tie your shoes, don't you? And I said, yes, they definitely taught them that. And she goes, well, that's a surgeon's knot. So just, you'll help me close and you can tie the knots. And after the case, it was about 2 a.m. Patient woke up fine. And I went to the library and got a book on surgical knot tying out. Went back to the operating room and got some old suture that was expired, but it wasn't, didn't have blood on it. And then I went back to the dorm and I was tying knots to the bedpost based on the book. And then in the morning I operated with her all day. And she said, I don't know when you practice this, but somebody practiced something between 1 a.m. and 6 a.m. And she said, you're going to be the closer with me for the month, the opener and closer. And so I opened up every wound with her and closed every wound. And I was like, I cannot believe someone's going to pay me to do this for a living. And that was the beginning of my neurosurgery career at MCP Drexel. And then I went to do my formal training at Hopkins, for another 7 years, then a year in Switzerland and a year in New York at Sloan-Kettering. And now I've been operating for the last 27 years since training. And it's hard to believe. I've been involved with 2 twin separation where they were joined at the head with Dr. Carson, the gentleman who wrote Gifted Hands, who's just really an amazing surgeon, just a wonderful, gifted and just a very humble human being. And but he's in politics now, but he was just an amazing person to operate with. And so that's kind of in a nutshell how I ended up in neurosurgery.
Wow. So it seems like your early, exposure to surgery and also neurosurgery in medical school really led you down this path.
Yeah, I really thought it was just the most amazing thing ever. And I was pretty clear when I did my training at Hopkins to say that I probably am not going to be somebody working on a bench doing like a bunch of like studies with things that you can't see in a petri dish. I probably will just end up being a surgeon who likes to help people and will learn techniques to do better surgeries. And the people at Hopkins, to their credit, sent me to Switzerland and then to New York to be with some of the best neurosurgeons in the world. And then I was able to bring a lot of that knowledge back to Maryland, which was wonderful. And really, I'm very grateful to Johns Hopkins and the university, for just being so open-minded to let me go do what I wanted to do and not necessarily do what a lot of people do, which is go to a lab for 2 years of the training. I just kept operating, which I think probably made me a better surgeon.
Absolutely. And could you give us a little sort of day in the life of when your day starts, what kind of patients you'll see, when you'll be in the OR, and when your day ends?
Yeah, so it's interesting because every day is so different. Whereas I think some people, it's always very similar, the day. And our day, there's some similarities, but there are definitely some curveballs that come. And so usually I get up at about 5:45. I used to get up earlier when I trained. I'd get up at 4:45 for a lot of years, for a good 7 years. And then when I got down here in 93 to Anne Arundel County, I got up probably at 5. And I think as time's going on, I get up more like 5:45. And then I go to the hospital, see the people that I operated on the night before, the day before, or the day before that, and see any consults that I didn't have to see in the middle of the night, or if I operate in the middle of the night, I'll see those people. And then either I'll go to the office and see patients in clinic for the day, or I'll go to the operating room. And being down here, there are just 2 of us that do neurosurgery. And so at any given moment, I could be in clinic or in the operating room, and somebody else could show up that needs surgery. And so it's a matter at that moment of trying to balance out, how to be in 2 places at one time, which sometimes is a little challenging, which is awesome to have the backup of another partner who is wonderful. I have my partner, Dr. Liang, who is just outstanding, just a rock star, who trained in Maryland and then was up in New York and been with me now going on like 8 years. And he's amazing. And then in the past, when I was at Anne Arundel, one day I was operating on somebody else, and a young woman came to the ER in 2001. And they said, "Can you talk to the ER?" And I said, "Well, I'm operating." And they said, "Well, they want to talk to the hold the phone to your ear." And I said, "Yep, what's going on?" They said, "Well, we have a young woman who is in the emergency room, and she looks like she's brain dead. She has a catastrophic, huge bleed in the brain, and she has no exam, and she's only 19 years old, and she's pregnant." And I was like, "Wow, that's not good." And so I had just hired a partner who was a really good guy in Annapolis. And I said to him, "Hey, can you close and I'll run down the ER? Do you want to go to the ER?" And he said, "Well, you're a little older than me, not much, but you should go." And so I went to the ER, and some guy said, "Who are you?" And I said, "Well, I'm Cliff Solomon, the neurosurgeon." And I came to see what's going on. And he pushes me against the wall and he started cussing at me. And he said, "Listen, you MFer, you have to save my daughter's life." And I'm like, "Well, you have to stop choking me so I can see your daughter." And I went back into the trauma room, and she was kind of what they said. She looked like she was in a deep coma. There was blood everywhere throughout the brain. And there was really nothing to do except do nothing or try to salvage the situation, and not knowing what would happen. And in life, I kind of feel like if you see trash on the ground, you can walk by it, and act like you don't see it, or you can pick it up. But to not act is to act, if you know what I mean. Like, you don't do something, you're doing something by not doing something. Most times it doesn't matter. There's a piece of trash on the ground. In this case, not doing something meant a 19-year-old person is dead, and so is her unborn child. And so I called my friends at Hopkins, and they said, "This is not going to end well, and they'll probably sue you and put you in jail and say you killed her and her baby." And I said, "Wow, you're such an optimist." And I had come back from Switzerland, where this guy there was like Michael Jordan of these vascular things in the brain. And I thought, I probably can't make her any worse, and maybe we'll save the baby. Who knows what'll happen. And so my other partner had finished the other surgery. I wheeled her up to the operating room. We operated on her. It was dominant hemisphere. She was already in a coma, but the breathing tube was in, and we made an incision from here over here, took off the whole side of her forehead and side of her skull on the left, took the bone off, opened the covering of the brain. The brain was kind of coming out at us like the blob, like Jello, and very quickly got into the blood clot, and the clot had done a lot of work. And then something I figured was bleeding deep beneath the surface, and thought, well, if we get her off the operating table, we'll come back another day and we'll deal with that. And sometimes you make plans and God laughs. And I think what makes you a good surgeon or a better surgeon is how you deal with things when they don't go quite as planned. So when I got the blood clot out, which is probably about the size of your fist and a half, blood started squirting out of her head over my shoulder. And so whatever was actively bleeding was still bleeding. And so we very carefully got around what turned out to be a tumor of vessels that were weakened by her pregnancy. And because of the increased blood supply to the fetus and the brain, it ruptured. And it wasn't an aneurysm, which I thought it might be, which would have been a lot easier to deal with. You know, aneurysms are tough, but it's one vessel, you know, and you put a clip on it deep in the brain, and that usually cures the patient. Unfortunately, this was a tumor of hundreds of thousands of vessels that when you get to the end of it, there's usually a vein or an artery. And if you take the wrong vessel, it blows up and they die on the table instantly. And I'd seen that before. And I really was not prepared to do this. And I was asking them if they had any clips there in 2001, and they didn't. And they said they had some surgical clips, but not neurosurgery things. And I was like, why don't you get those? And, you know, we'll try and, you know, like a rock and a sharp stick, like duct tape, we'll try and figure out how to make this work. And we got down to these last two vessels, and I put a clip on it, and I was waiting to see if it started to blow up, and I was gonna pull the clip off and put it on the other vessel, because one's the arterial inflow, one's the venous outflow. And the whole idea is you want to take the inflow before the outflow. Otherwise it blows up. So anyway, I put it on, nothing happened. Felt safe that that was the artery, took the vein, then lifted this thing out, and then the brain went back into her head and started pulsating and pinking up again. And I thought, maybe, you know, we caught a break today. I left to drain deep in the brain out to a bag, and bright red blood was coming out of it that night. And then the next morning she woke up. And then the next day it was a little less red in the bag. And then after 9 days, it was back to pink, and then yellow. As blood breaks down, it turns yellow. And then it was like vodka, like clear. And she went home post-op day 9 or 10 and had no deficits. She was awake, talking. And then 8 months later had her baby, and that child's now 20 years old. And was one of those things that was just very humbling that, you know, you never forget. You know, I've had a couple things like that happen where it's kind of like at the right place at the right time. But, you know, very, you know, I'm not super religious in that I don't, you know, go to, you know, church a lot, but I'm super spiritual in that I always say a prayer before I operate. And one time Ben Carson looked over at me and said, "Hey, are you saying a prayer?" And I said, "I am." He said, "I do too. Between the two of us, we're covered." And I said, "Yeah, I think so too." And I always feel like, you know, someone's doing some work through me somehow, if that makes any sense. I don't know how else to explain it, because I've just had a lot of things happen to
Yeah,
me,
absolutely.
you know, where I've just been in the right place at the right time. I had the guy at Anne Arundel in the old hospital when it was down in Annapolis, where I walked in to see one of my partner's patients. And I said, "Where's so-and-so?" He said, "Oh, he left." And I said, "Who's that guy?" And they said, "Oh, he's just a drunk guy in the corner." And I walked over to him, almost drawn to him. And he was in a coma. And I said, "What happened to him?" They said, "Well, as far as we know, he was drunk." And I said, "I think there's more to it." And I wheeled him to the CAT scanner. And it turned out his cousin hit him in the head with a frying pan. And he had a gigantic blood clot in the brain. I called the OR, and they said, "Yeah, we've got a bed, you know, we've got a room for you. We've got anesthesia." So I wheeled him up to the operating room, operated on him, took out a bunch of fractured skull, blood clot in the brain. The guy woke up, was totally normal. And then he came to see me in clinic like 3 months later, and he had a baseball cap on. We took it off. You could see his brain pulsating. And I said, "You know, dude, we can fix that, you know, easily and put bone there, you know, or a piece of metal, and you can't see it. And then we'll put your skin over it. I mean, it's like plastic surgery, you know, and we won't." He didn't have insurance. I said, "You know, there's, you know, all this is, you know, it doesn't cost you anything." And he said, no, that's way too dangerous. And so I said, "Well, you can keep wearing the hat, but just don't go dope, or don't go. I could have had a V8, you know, and be careful." But he was fine. So kind of crazy. Mm.
And let's see. And you mentioned some of your most memorable cases, but what would be some of your like bread and butter cases, the most typical operations you would do these
So
days?
on a daily nowadays, I do a lot less brain surgery, although we still get the subdurals, people that get bonked on the head, or people that fall that are on blood thinners and acutely we have to race to the operating room, take out a blood clot. Or I had somebody show up with a brain tumor last week about the size of a orange that we're going to take out next week. But normally the bread and butter stuff is the spine. I try to be super conservative. And if people are really young, occasionally I'll get like someone who's like 18 years old with a herniated disc, like an athlete. I had somebody from University of Maryland had a broken neck. I had another guy from Maryland who was a lacrosse player who broke his neck. And both those people we operated on and fixed the broken neck. But besides those things in the young person, the most common thing in the older folks are getting a herniated disc or stenosis, narrowing of the spinal cord. And so if you get stenosis or narrowing of the spinal canal, most of the people are older, or if they're like little people that are achondroplasts, that sometimes people in the past refer to them as the little people. Sometimes they get congenital, they're born with it, spinal stenosis. And basically we give them a bunch of medicine to go to sleep. They're face down and we make an incision wherever the narrowing is. In the little people, the narrowing can be from the skull all the way down to the tailbone. But in most adults who get it, they're usually in their 70s or 80s. Sometimes, again, they're born with it. But we'll make an incision about this big on their low back or their neck, and we'll drill away the bone that's pushing into the spinal cord. And the bone is kind of like tree branches on phone wires. And so we very carefully drill. So yesterday I did 2 of those in the neck, and then the day before I did another one in the neck, where we drilled the bone that's pushing in the spinal cord till it's paper thin over the cord, and then very carefully lift the bone off the cord. And then you can watch the cord go from like a millimeter back up to about 18 millimeters. And usually the 3 I did this week, all 3 patients woke up feeling like their arms were much better. It's interesting. The younger person had more pain than the 2 older people, and said that his neck he wasn't happy with me the night of surgery. He said he was cursing me, but the next morning he said it was better. And then today, markedly better, and actually going home. But that's one of the more common things we do. Another common thing we do is if someone has a herniated disc, there's the square bones in the neck, and then between those are the discs, the cushions, and sometimes the cushion will crack and disc material go into the spinal cord and hit the nerve going to the arm or go straight back into the cord. And so if people fail conservative therapy, I always tell people the best surgery we do is none, that we're the last resort. But if you don't get better, 85% of people with a herniated disc in their back or their neck get better with time and conservative non-surgery. But if they don't get better, then we give them some medicine, make them go to sleep. We make a little incision here on the neck on the left. I go on the left and move this muscle, the sternocleidomastoid, over that way, the carotid artery that way gently, the breathing tube and the feeding tube with the trachea and esophagus that way. And then we're staring when we put the retractor in at the spine. And then we get an x-ray to prove we're in the right place. And then very carefully with magnification, either loops, glasses with the headlight and magnifying glass on my glasses. You can see with the headlight, because it's kind of a deep hole, sometimes it's really deep. We take out the disc back to the spinal cord and then replace the disc with something artificial or with a piece of cadaver bone or a piece of helicopter plastic, and sometimes a little plate on top of it to hold everything in place. We look around, make sure nothing's bleeding. Very carefully take the retractors out, let the carotid go back in place, let the trachea and esophagus go back into place, and then look around, make sure nothing's bleeding, the wound's nice and soft, wash it out. And then we give the patient a free facelift. We tighten up the platysmal muscle and then close the skin and then sneak back out. And usually, amazingly, they go home the next morning. It's pretty insane. I mean, I don't know who invented this, but it's pretty nuts. There was 2 guys at Hopkins, Smith and Robinson, that were the beginnings of this surgery. And over the years, when I trained in 1986 to 93, this was a relatively new procedure. And now it's been around since then and only gotten better and better and better. In the old days, we took hip graft to put in the neck. So a person would often complain their hip hurt, but not their neck, from us taking the graft to move it into the neck to put it into the disc space. Now we have some artificial things we put in. And then the other common thing we do is take out herniated discs in the low back. So a disc will come out of the disc space. The disc is like a stale jelly donut in the low back. 85% of people get better without surgery. If they don't get better, then we'll give the patient a bunch of martinis. They go off to sleep. They're not martinis, and they're face down. We make an incision in the low back in the bones that you feel with your finger. And we take an x-ray to prove we're at the right spot. We can usually do it with a pretty small incision. And then often we just come down on one side where the herniated disc is, drill a window opening in the bone of what's called the lamina of the level where the disc is herniated between two bones. So L4-5 usually, or L5-S1, those are the two common ones. And then there's a little ligament underneath there. We very carefully take that off. And then we're staring at the tough mother, the dura mater, which is the covering of the spinal cord. And very carefully, we retract the dura mater and the spinal canal with the nerves in it off the midline. And we'll see the herniated disc. And very carefully, we'll pull it out. Looks like a big piece of crab meat. And usually that gets a big, it's a crowd pleaser. And then we check that the nerve is happy going out the little hole down their leg. And we make room for the future if they were to collapse the disc as they get older, so they don't have to come back. And we rotor out that little opening and then close it back up. Usually we lose very little blood. I don't think I've ever transfused anybody. I've done a couple thousand of these now in the last almost 30 years, more than 30 years, including my residency and fellowship. And that's probably the most common thing I do, that and in the neck now, and kind of the bread and butter. And usually those folks go home in a day. Usually they're healed up by 4 to 6 weeks. And it's pretty rewarding that people like tell you they feel better. I mean, you don't make everybody better. I mean, but the overwhelming majority of people are like, you really made me better. And it's just something really wonderful about someone saying that they're miserable and that, they feel great. And that's a really rewarding thing. And I think some doctors sometimes, and people just in general, forget that, it's just being nice goes a long way. I mean, it's very helpful to be competent, but it also is just really good to be human and, compassionate, and then, do what you're supposed to do. And people seem pretty happy.
Absolutely. And I think, the humanistic part of medicine is something that's so important. And sometimes it can be overlooked with, hospital bureaucracy and things of that nature. So, talking about our healthcare system, what do you think are some of the strengths and weaknesses of our current healthcare system?
I think we have probably the best care in the world in terms of technology. And I love that, that people are always trying to do things better. I think sometimes we miss a little bit the forest from the trees about what's really at stake. That I think if we always just put the patient first, you're going to always do the right thing. I think it's pretty simple. And I think that as we try to figure out the bureaucracy, we have to figure that out. How do we, lessen the bureaucracy and really, just really be patient focused, I think that's the key.
Absolutely. And the other thing, going back more towards neurosurgery, you mentioned how patients are, with many procedures, they can go home the same day or day after their procedure. And certainly that probably didn't used to be the case 20, 30 years ago.
When I first started, people stayed for a week, 2 weeks, pretty routinely. And they came in the night or two before the surgery pretty routinely. And now it's gotten way more like drive-through. I mean, it's a little crazy.
Right. And what other, technologies or advancements in neurosurgery have changed since you started? And what do you sort of see happening? What technology or advancements do you see changing the field of neurosurgery?
So I think because technology, we're often married a lot to the defense industry. I think defense industry gets technology and then it trickles down to us pretty quickly. And so when I first started, we were looking at image guided surgery. So we were looking at GPS for brain surgery. And when I first started at Hopkins, I remember having a ruler and measuring out where a brain tumor would be on the CAT scan and then measuring the patient's head. And the engineers were in there with some gadget and they were saying to touch it to the head and they could show us where it was in the CAT scan. In the beginning, it wasn't so accurate. And then over time, it's now more accurate than I was with my little ruler. Now, if the machine breaks, which technology can break, it's not common, but I can remember very distinctly at Hopkins years ago, operating on somebody very well known whose child got hit by a car. and I came to the ER, and he had blown pupil, which is a sign of impending death. And he was weak on that side. So normally, if it's the pupil is big on the left, the pathology is on the left. But if they're weak on the left, the pathology is on the right. So it didn't make sense. So I said, so the people in the ER said, so where are you going to operate? And I said, well, we'll look at the CAT scan. And they said, well, the CAT scan is broken. That's interesting. So another one of those defining moments. And so I got my little neurosurgery book out and read which is the more localizing sign. And it said the pupils don't lie. So if the clot is on the left, 90% of the time, the pupil will be dilated on the left, and that the weakness on the left is a false localizing sign. It's not real. And so I took the young person to the operating room, opened up the left side of the skull, big clot, took it out. This child woke up, was totally normal. But if I had not seen blood, the residents had asked me what I was going to do. And I said, well, we'd open up the other side, which in the old days, apparently before CAT scan, that's what they did all the time. That's kind of interesting, kind of like really seeing technology. Kind of reminds me of Indiana Jones, where, the guy comes out with a sword, and he just shoots him, And I think that when I look back on that now, to the point where we are now, almost 30 years later, I operated yesterday in the operating room where I have an intraoperative CAT scanner, which is just insane. So when we put hardware in the neck, screws, if we have to, we can see in virtual time, CAT scan's done, and then we can use virtual time to see the trajectory and the placement of the screws. So they're between the artery that goes to the brain and the spinal cord through a very narrow corridor, which before we had to just use our knowledge of anatomy to do that. And now we still have to use our knowledge of anatomy, but there's a really nice safeguard in that we're looking like GPS, exactly where that screw is going. And then we get a post scan after it's in. And so if we're not happy, or the anatomy is weird, or there's a vessel weird, we should pick up a lot of these anomalies to make the surgery safer. And I think that is something that's a game changer, that we'll see more and more and more of this image guided virtual surgery with a way to check what we've done before we close the patient up, which is key, which is new. And so that technology is here, and it's amazing. I imagine in the next couple of years, we'll be doing this with robots that I don't know if it'll look like the Jetsons, but I think that I will probably line up where we think the hardware goes, and then a machine will do it instead of us. There are some of that out there now, and there are other things that are coming, and I think that will come to neurosurgery. Seems to get a lot of toys and technology sooner than other fields. But I think that will trickle down through thoracic surgery, cardiac surgery, the oncology surgeons, all this technology becoming automated, and then ultimately potentially being somewhat remote in remote areas of the world, where I could be back at Maryland or Hopkins or wherever someone could be and do the surgery remotely. And I think that's in our lifetimes, we'll see that. And that's kind of exciting, for people that live in the middle of nowhere to be able to get a very sophisticated level of care.
Yeah, absolutely. And what do you think the importance is of getting this very specialized surgical care to maybe more rural areas, or areas where there are disparities and inequities in their healthcare?
Yeah, I think it'd be great to figure out a way to get everybody covered. I think everybody in America should get the ability to get coverage. I mean, all you have to hear is some of the stories of people losing their job, or who have had a streak of bad luck, or get injured. And, there's no judgment. There's no badness to this person. This is just life, And so when I was in Switzerland, I lived in France for a bit. Everybody got covered, and I thought that was a really good way to deal with things. In my training, I tried to never turn away anybody because they couldn't afford anything. I've over the years I've argued with people to do things, but I used to ask Ben Carson routinely as a resident and Dr. Long at Hopkins, and occasionally call Maryland and talk to Howard Eisenberg and say, hey, I met so and so in such and such place, different country, our country, on vacation, visiting a relative. They don't have insurance, and I've never had anybody ever say to me, no. They've always said, sure, figure out how to get them to us and we'll do the surgery together, or you can do it, or we can do it. And I love that. And I hope we never lose that attitude. I think as doctors, the overwhelming majority of doctors feel that way.
Well, that's great to know. And in terms of getting into medicine, what was the most challenging part of becoming a physician in your perspective?
I think you just have to be persistent. I remember very early on, I was in college. I raced through college in 2.5 years, which that probably was a mistake. I don't know why I was in such a hurry, but I had enough credits to graduate. And so I thought, why not? When I look back on that, probably it worked out very well, but I was ahead. And when I went to interview for medical schools, they're like, you're like 2 years younger than everybody else, at least. And I think, you should take a year in a lab. And I really didn't want to do that. And so I only applied to a few medical schools, but one medical school said we would take you if we had known about you, but I hadn't applied there. But they said, we have a program in France. And if you do the program in France, you can matriculate back into our class. And I spoke French. I'd gone to France for part of those credits that I'd gotten ahead during a summer. That was one of the things. And then the other was I just took a whole bunch of credits freshman year, which put me way ahead. I think I had 30 credits the first semester, and I was going to drop stuff that I didn't like or wasn't doing okay. And I just seemed to be doing okay in everything. And so I just kept them, and that 30 credits put me ahead. And then that summer I was in France, that put me another 15 or 20 credits ahead. So I would say, so going to France turned out to be amazing. But when I got there, they said, oh, don't worry. They send Americans over from Harvard and from Pennsylvania and all over the place. They get a free trip to France out of it. They love teaching the Americans. The French love the Americans, and it'll be great. You'll love it. They speak slowly. When I got there, it was a nightmare. I was living in the basement of a monastery, and they spoke extremely quickly in French. In medicine, I had no clue what they were talking about. And I thought, oh my God, what have I done? I'm going to end up flunking out in France and never be a doctor. As it turned out, it probably made me more serious as a doctor being in France, because I thought the risks were so high that I made sure I did really well. But I definitely felt like I learned, like Gilman had taught me, and college to some extent, about just getting my work done first and then going out and having fun. And that was very helpful. And then when I matriculated back to Medical College Pennsylvania, which is now Drexel, I definitely felt like I had learned how to study in France. I mean, it was interesting learning it in both in English and in French. And that experience, I think, kind of really landed on me that, persistence beats resistance, to really just be very focused on your goal and not be deterred. And that theme seems to come up in my life, that, when things get tough, it's okay. Just get focused and push through it. In French, they say serrer les dents, which means grit your teeth. But it seemed to be a good thing. And also, to have fun doing it. I think that's key. And in our operating room, there's no yelling, there's no screaming. If things are challenging, everybody in that room, it tries to help me. And I've been so lucky in my career, so lucky. And just always feel like there's some higher power watching over me. But I really feel that part of that is kind of what you put out into the world. I just think it's good to be kind and, humble.
Absolutely. I think that's a really great message. So unfortunately, this is all the time we have for today, but I want to thank you
glad
so
we get
much.
to talk.
Thank you so much, Dr. Solomon, for taking time out of your busy day to talk with us about your profession. We really appreciate hearing your perspectives. Do you have any words you'd like to leave with students who are interested in pursuing a medical career?
Yeah, I would just say stay focused, be open-minded. If you really want to do something, whatever it is, whether it's being a doctor, anything in your life, I would say there's nothing you cannot do if you're willing to pay the sacrifice to pay. There's no magic to this. I love doing magic. There's no magic to this. The magic is just staying focused and just doing a good job. Be nice along the way and try to be present in life. I mean, this is your life right now. This, you and me talking, this is your life. And I do see a lot of really serious things. And I talk to people about very serious things every day. I never know what's coming my way, who's coming my way. And I just think as much as you can, just try to stay focused on what you want and don't let people detract. People sometimes they get in a funny way and they just can't help themselves, and just kind of be compassionate that they just don't get it, and just be present. Someone I knew, I'm sure he wasn't the first person to say this, but he said, yesterday is history, tomorrow is mystery, today is the present. That's why it's a gift. And just enjoy today and just try as much as you can just to put one foot in front of the other one and just do the next right thing. And when you get a little lost or you don't do what you're supposed to do, don't be too hard on yourself, but just get refocused. And sometimes writing down what it is you want as if you've had it already, even though you don't have it yet, but saying that you have done what you wanted to do is a nice way of reminding yourself how to move to that goal. And then if you're doing something where you're like, I really shouldn't do this, then try to change the behavior and say, yeah, I want to be doing this to get to that spot. And, it's not like, McDonald's, it's not drive-through. After grade 27 of schooling, I do this crazy thing to people, and I'm very grateful to be able to do that. But I look back and think, if I can do this, anybody can do anything.
That's great. Thank you, Dr. Solomon.
Yeah, good luck.
To everybody watching, please stay tuned for our next guest speaker event. You can stay up to date by following at FHHMO on Instagram. I would like to thank Dr. Ting Ting Wong for making this event possible. To check out all of Future of Human Health and Medicine organizations' initiatives, including Teen Mental Health Night and Healers Podcast, please visit FOMO.org. Thank you again to all of our viewers and have a great evening.